Hello, everyone. My name is Dr. Brian Ho, and I'm a neurosurgeon. And I had the great privilege of being the chair of the writing group for these American Heart Association and American Stroke Association updated guidelines for treating patients with aneurysmal subarachnoid hemorrhage.
And my name is Nerissa Ko. I'm a neurointensivist and vascular neurologist, and I also had the privilege of working with Dr. Ho as the vice chair for the writing group responsible for the updated guidelines on aneurysmal subarachnoid hemorrhage.
Seizures are another big risk for aneurysmal subarachnoid hemorrhage patients. And first, it's important to know what makes a patient more at risk for seizure. Fluctuating neurological exam and depressed mental state, ruptured MCA aneurysm, high-grade subarachnoid hemorrhage, presence of intracerebral hemorrhage, hydrocephalus, or cortical infarction. For these patients, continuous EEG can be a good idea to monitor for possible seizures.
That being said, we need to be careful with prophylactic or anti-seizure medications. We should not use anti-seizure medicines in all patients, but only consider in patients who have higher risk for seizures. In particular, the use of phenytoin is not recommended because it's been associated with worse outcomes after aneurysmal subarachnoid hemorrhage. If a patient has actual clinical seizures at the time of the hemorrhage, then we would want to treat those patients with anti-seizure medicines for 7 days. Treating patients with no prior history of epilepsy and no high risk features for longer than 7 days was shown to have no benefit. If a patient has seizures in a delayed fashion during the recovery from a hemorrhage, then that's a different story. In this case, we would treat with anti-seizure medication similar to in other scenarios for a longer course of treatment beyond 7 days. This is a new way of approach to seizures, as we used to treat all seizures in a similar vein. And now we would want to really think about, are these seizures actually happening as a result of an acute reversible injury? Are they a prodrome to more chronic seizure disorder because of acquired brain injury? And more, less use of preventative seizure medication when there's no seizures at all.